So I'm just talking about first-line therapy with CLL, and that's become a lot clearer in the last few years due to some excellent international collaborations and clinical trials. What people forget, though, the treatment really starts actually with infection control. Every new patient being seen should be warned about infections, so they should be advised about the need for vaccinations. In the UK, pneumococcal vaccination, it's got to be the Prevnar, not the Pneumovax vaccination. Pneumovax is very ineffective in CLL patients. Prevnar is what you actually need. Likewise, Haemophilus influenzae B, meningococcal C, there's a combined vaccine called Monitorix, and all new patients are given that regardless of whether they need treatment. And that's very important you get it early on, because your immune system is much better early on in the disease, and you're more likely to get a good response to it rather than wait 3-4 years down the line. But if by chance you're a patient who hasn't had it, it's even better to get it late than never. It's very important to have the annual flu jab, but the truth of the matter is only 10 to 15% of CLL patients actually get immunity from the flu jab. Much more important is to get your partner immunised, because you're most likely to catch it off someone close to you. So even it may do you no good having it, make sure they have it, and it's hard to get them to do it if you don't have it as well. But get them down to the doctor and get them vaccinated. If people do get infections, they need early treatment with antibiotics. It's phenomenally important, and a lot of patients need a prolonged course of antibiotics. We live in a world where everyone's worried about antibiotic resistance, and that's very true. But in CLL, 5 days of a low-dose antibiotic for a lot of patients is just simply not enough. You need a full dose, and you typically need it for 7 to 10 days. For those patients who do have hypergammaglobulinemia and infective complications, it really can be a life-changer, intravenous immunoglobulin. Expensive, but very necessary. The most important thing for a CLL patient is to stop smoking. When patients say, what can I do to help myself, diet, exercise, 50% of CLL patients who smoke will die of a chest infection with or without treatment. So if you want to do something to help yourself, stop the cigarettes, save the €7 a day, put it towards a nice holiday in Barbados or something along those lines. Arnon touched on earlier about why don't we treat straight away. It seems a bit ridiculous. You've got cancer, or go away and leave me alone. There is no evidence at the moment that actually early treatment makes any difference to the outcome. But this data is very much based on early studies from the French group, and there was a smaller study in the UK showing that chlorambucil added to patient care early on made no difference. In fact, they had a few more problems with it due to the side effects of chlorambucil. This is now being all revisited in the light of more effective, less toxic drugs. So we may actually be going back to treating early stage patients, but at the moment the standard dogma is watch and wait. The indications for treatment, there's actually an international set of guidelines, international workshop on CLL, have actually defined when you should actually start treatment on patients. Constitutional symptoms, fever, night sweats, weight loss, and fatigue. The most difficult one of those is fatigue, because actually people can be fatigued for a lot of reasons. It may not necessarily be their CLL. And I've had several patients who really have very little CLL to talk about, no lymphadenopathy, no hepatosplenomegaly, a very modest white count, who tell me that absolutely shattered. And it's very difficult to press the button and give them treatment. But about half the patients I have, they've actually felt a lot better for it. Half it made no difference because it probably wasn't the CLL, but the other half actually did improve from it, even though they appeared to have very early stage disease. Other reasons for treatment are falling hemoglobin or platelet count, or enlarging lymph nodes, liver or spleen. Kostas is going to talk about P53 abnormalities straight after myself. That is the most important test. And to me, no one should be having treatment unless you know the P53 status of the patient, because that determines what therapy you should have access to. But I recently reviewed a paper from the United States. 50% of patients did not get P53 testing before treatment. And I really don't know how you can give the appropriate treatment if you're not doing that particular test. That's the most important test. We then look at the comorbidities of the patient, and the Germans have come up with a great little line of go-go patients, those fit for anything, no-go patients, those people virtually fit for nothing, and the rest of them in between the slow-go. Go-go, slow-go, and no-go. I'm not sure anyone wants to be in the no-go group, but we're probably all heading there at some point. It'd be great if patients had a choice in their treatment, and hopefully you will have when you talk through with your clinician what's the best thing for you. And of course, you can't get away from some countries have more wealth than others and the affordability of the various therapies. When you actually look at the patient group we're looking at, though, this is just an unselected cohort of patients from this study. 75% of patients had a comorbidity. Phenomenal number of our patients have hypertension, joint problems. We really are a healthy bunch, hyperlipidemia. So it reminds me a bit of Wales. Yeah, fat, smoking, hypertensive, it's the norm actually, it's just the phenotype we get brought up with. But you've got to take into account the comorbidities, they're phenomenally important. Again, we're seeing more and more patients who've had other cancers. And this is quite an interesting slide. On the left, we have a higher rate of non-Hodgkin's lymphoma. That'll be partly the Richter's. Then there is a higher rate of Hodgkin's disease. Part of that's Richter's. But in fact, we know those genetic abnormalities that make you prone to CLL also make you prone to lymphoma and myeloma as well, as it turns out. AML, that is probably related to the toxicities of some of the therapies that have been traditionally used. But even if you look at all the other cancer, there's a higher incidence of them, which is harder to explain in patients. So basically, the studies, MD Anderson led the way by introducing the regimen fludarabine, cyclophosphamide, and rituximab, and proportion of live overall survival was significantly better than if they had fludarabine on its own or fludarabine with cyclophosphamide and or mitoxantrone. So they led the way, and then the German CLL study did a randomization of FCR versus FC, and you did significantly better with FCR. We now know, as I said, with later data, that we're probably curing 10-year survival, 50 to 80% of those patients with mutated VH genes. The depth of response matters. Again, I talked yesterday about minimal residual disease, that of course, the more your disease goes away after standard therapy, the better you do. If by chance you still have active disease or measurable disease at the end of treatment, your disease is going to come back quicker, and you're actually not going to survive as long without getting access to the new agents, is the truth of the matter. A lot of popularity for bendamustine rituximab, but in fact it's not as good as fludarabine cyclophosphamide rituximab. That doesn't mean it's not a perfectly reasonable choice for patients with comorbidities, renal impairment, where you'd be worried about giving FCR, but it is an inferior choice overall. But I still use it. So for the go-go patients, fludarabine cyclophosphamide rituximab, unless you have a reason not to. It's interesting in North America, fludarabine rituximab is still a very popular regimen and a very effective regimen. It's not really been any big head-to-head study. But in the US, fludarabine rituximab is a very common therapy. But in Europe, in MD Anderson, Texas, it's FCR. Going on to the slow-go patients, this is actually the German CLL 11 study, which has been reported over the last 2 years. And what it did was compare chlorambucil monotherapy, chlorambucil monotherapy with chlorambucil rituximab and chlorambucil with obinutuzumab. Originally, the study opened up chlorambucil obinutuzumab, then chlorambucil versus CR, chlorambucil rituximab, and then they closed the chlorambucil arm and did a head-to-head comparison. Really big study, over 800 patients. And the average age of this patient is much older than seen in any other study. But 781 patients across Europe, although it's called the German CLL 11 study, about half the patients were from across Europe, outside Germany. If you look at the demographic, the average age is 74. That's more like it. Those are the sort of patients I see walking through the door. The average age of diagnosis now is 72. If you look at those FCR data, a lot of them, the average age is 60 of the patients in them. So we get into the real world, as I would say. I love this. 90 years age in your clinical trial. Absolutely fabulous. You're never too young to go into a clinical trial. Absolutely brilliant. Good for them. The SIR score is a measure of comorbidity, and score of 8 is really quite high. That's comorbidity, heart, kidneys, musculoskeletal, all those things that matter about outcome. Again, it's back men do worse in women, but actually they did seem to have quite healthy kidneys for given the age group of the patients, dare I say. To cut to the chase, progression-free survival, significantly better with chlorambucil obinutuzumab than it was with chlorambucil alone. Time to next treatment. Progression-free survival for patients isn't a very meaningful thing, because in a clinical study, progression-free survival, if your lymphocyte count goes above 5 and you get some nodes that grow, that doesn't mean you need treatment. That doesn't necessarily mean you need anything. But PFS is the hallmark of clinical trials. For patients, what really matters is when are you going to get treatment again. And in this study, actually, it's over 4 years with chlorambucil obinutuzumab on average before you need retreating. And that's significantly better than chlorambucil alone. Overall survival in this study was actually significantly better with the combination than chlorambucil alone. If you compare obinutuzumab chlorambucil with rituximab, again, it's actually a superior combination as obinutuzumab than chlorambucil. Then chlorambucil rituximab, albeit the chlorambucil rituximab is better than chlorambucil alone. Time to next treatment again, better with the combination chlorambucil obinutuzumab, and overall survival, in fact, is no difference between the two. But of course, while this study was going on, the new agents were beginning to appear on the horizon that actually could salvage some of your patients by using the new agents. But if you want to save money, you get a bigger bang for your buck using your most effective agent up front, which is chlorambucil obinutuzumab, because you can probably salvage your patients later on with the new agents. The overall response rate is significantly higher and more complete responders in the combination, as in keeping with actually hitting the disease harder. The amazing thing with obinutuzumab, and I really didn't believe it when I first saw it, but the preliminary data showed no matter what your white count was before treatment, after one dose, it was always less than 10. Be it 200, 300 or whatever, it was always less than 10. And virtually all the patients in the study, that's actually what happened. And when we did the study, the thing that actually everyone noticed is infusion-related reactions. This is not rituximab. People reacted initially very badly because initially there was no prophylaxis in the study at all. Then they suggested hydrocortisone, that was no use. Then they realized a lot of the reactions were dropping the blood pressure, but this was happening within seconds of giving the dose. And I don't think it really is an infusion-related reaction. I think it's cytokine release because the obinutuzumab is killing the cells there and then in the circulation. And you get a massive cytokine release giving you infusion-related reaction. So throughout the study, they had to learn how to actually stop the reactions. And eventually, by the end of the study, they worked it out. It is more toxic, slightly more neutropenia than you see otherwise. Not really many more infections, slightly more thrombocytopenia. The infusion reactions are really the thing that worry people. You do have to take precautions. You have to give the steroids, a big dose of steroids, at least an hour before you give it. You have to make sure they haven't had their antihypertensives that day, or they're more likely to react. But the good thing is, it's a day 1, day 2 phenomenon on the whole. And that's because after day 2, you haven't got any peripheral lymphocytes left in your blood. It's all cleared. Similar study, this was a UK study showing chlorambucil ofatumumab versus chlorambucil, showing again ofatumumab with chlorambucil was better than chlorambucil alone. For those people who like bendamustine, this is the original Canal study showing that bendamustine was better than chlorambucil, but that progression-free survival of 24 months compares with 31 months for chlorambucil obinutuzumab. So I don't think bendamustine monotherapy is really much of a therapy at all, in all honesty. But then the new boys have arrived. This is a study with ibrutinib versus chlorambucil, the Resonate-2 study. Again, 73 years of age, 89, 90, excellent. I like to see that. Recent performance status, because in a lot of studies, you're excluded from a study if your performance status is 2 or more. So quite often you're getting a cleansed version of patients. By allowing patients with 2, score 2 in, is nice to see. Various stages of disease. Interestingly, 40-odd% unmutated. That's quite unusual. Usually it's the other way around. It's 60% unmutated, 40% mutated. So it's a bit odd in this study. I don't know why that is. But there's no doubt at all, progression-free survival, 80% at 2 years are still actually going really well compared to chlorambucil. This is an interesting one. Back to how would you spend your money. If you notice here, oops a daisy, sorry. If you notice here, the chlorambucil line, I'm trying to get it, goes down and then flattens out. And the reason for that is it took them quite a long time after opening the study to allow the crossover. When you failed chlorambucil, you could cross over to ibrutinib. It took in the best part of 2 years to get that into the study and up and running. And consequently, a lot of patients, I say a lot, a few patients succumbed while waiting for the crossover. Once the crossover came in, it all plateaued out. So again, if you want to save your money, what do you lose by going chlorambucil up front and then changing them over to ibrutinib? You'll probably save yourself 6 to 12 months of ibrutinib therapy. But in reality, I'm a great believer you should give your most active agent first. But if you're limited for resources, it wouldn't be a bad strategy. I'm not going to talk about maintenance therapy, but there's many licensed maintenance therapies available and many trials ongoing with maintenance for people who've got disease left after whatever treatment they had before. This just happens to be obinutuzumab, but there's similar studies with rituximab this is ofatumumab, similar studies with rituximab and obinutuzumab. And maintenance does help, but I'm really not sure it's a game changer, in all honesty. Future directions. Well, there are endless studies going on at the moment. The UK study for fit, healthy people is RFC versus ibrutinib R. We've got about 400 patients randomized in that study. We're aiming for 800, and it's going to be a very interesting study to see actually how well patients do with it. My personal feeling is RFC is going to be better mutated, and ibrutinib is going to be better in the unmutated. But the whole point of doing this study is to see whether that's right. There's other studies ongoing, bendamustine rituximab with idelalisib or ibrutinib. There's a study from Australia, RFC plus ibrutinib. It's a single cohort study showing phenomenal results in terms of PFS at the moment and minimal residual disease. It'll be very interesting to see how that develops, because that may be the next study for others. Bendamustine rituximab, lenalidomide, ibrutinib, obinutuzumab. What you notice is we're talking less about chemotherapy and more about the new agents. And chemotherapy may well drop out and become the salvage therapies of the future, because you wouldn't necessarily expect cross-reactivity between the two. So we're probably in a time when eventually the chemotherapy will fade out from routine care for a lot of patients up front. Risk stratification for patients, what do they need, what prognostics are telling should be best for them, predictive, and as I say, the scheduling, which treatment should you use before the other. So in conclusion, it says, early stages, still watch and wait, but watch this space, that may well change. No 17p abnormality. Really, you've got to have a reason not to use fludarabine, cyclophosphamide, and try and find a reason. In the UK, the FLAIR study allows you to use FCR with creatinine down at 30 mils a minute with an abrogated dose. That's really very low. Well, above 50, you get the full dose. In the original study, it had to be 70 mils for creatinine. Slow go, as I say, it really should be chlorambucil with one other antibody. Better rituximab or ofatumumab than nothing at all. Bendamustine rituximab for some, not over-impressed, but maybe an option. And ibrutinib, as I say, will suit these patients. And for what we called the no-go, we have to find another name for them, because actually I don't think there's any such thing as no-go. To be honest, chlorambucil monotherapy may help relieve some symptoms. Continual low dose, 2-4 milligrams a day, virtually no side effects. may do something for the patient. Rituximab monotherapy may well be good. And of course, ibrutinib, there's not many patients actually, you won't be able to at least try ibrutinib for. Those with atrial fibrillation, those with a bleeding history, maybe those who've not had previous BTK, but ibrutinib is going to come along for this lot as well. And that's me finished.
Thank you, Chris. Very interesting. I'm sure everybody's got a few questions. We do have time for some questions, so please. Peter.
You were mentioning at the end low-dose FCR, and there's also some people who don't make it through 6 rounds. What does the data say about those people?
So if you look at the lower dose RFC is being popular in some countries. There's been no real head-to-head comparison for how effective the modified RFC dose is. Personally, I'd rather give the full dose for fewer rounds. The German data from the CLL8 study showed you've got to get to about 4 rounds of RFC to get over 90% of the benefit. The last 2 rounds give you a bit more benefit, but not as much. Getting to 4 is always my first goal with patients. I'd rather give 4 full doses than 6 abrogated doses, in all honesty. The dose of rituximab is very interesting as well. There's a study being performed in the UK called Uptake, which is FCR versus FC rituximab 100 milligrams. And we're waiting for that to be published. The normal dose of rituximab is 375 milligrams per meter squared for the first dose and then 500 for the next 5. It looks like you get about 80 to 90% of the benefit of rituximab with 100 milligrams. The bigger dose gives you that added little bit more as well. So my usual rule of thumb is try and give the big dose if you can. But if you can't afford it, given a smaller dose of rituximab, it's still actually going to give you clinical benefit.
Charlotte.
So you said that every patient should be P53 tested before treatment starts, and that it seems in the US, half of them are not. Do you have any idea what is the situation in Europe?
I've not seen any published European data. I imagine it's very similar, to be honest. Yeah.
Microphone. You've got one.
It varies enormously from country to country, but even in the best examples, it's never more than 65 to 70% of patients who need it, and it can be as low as 20%, because we don't, when we refer to testing for TP53 abnormalities, it's not only FISH that we should be doing. I will say a little more about it in my talk in a while. So the situation is not ideal, far from it, and we need to do our best to try and improve.
I mean, if you take the RFC data, a P53 patient response rate's about 40–45%, and you have a much shorter response period. So it really isn't the appropriate therapy. It doesn't mean it won't do anything, but it's just not going to do as good a job, and you'll be back to salvage therapy quicker than you realise.
Hello. I have a few questions. You can stop me after one if you want, but well, Nick, I know other people might want to get in.
You have about 3 minutes.
Okay. I'll ask them quickly. When the novel treatments become available frontline, will you treat earlier?
I think that's going to be a separate issue. The early stage patients, we need studies to say that's right. But you're absolutely right. The tendency is to treat earlier, the less toxic your therapy. Less cerebral matter put into the decision. It's much easier to be trigger happy if you've got something which you know is effective and safe.
Okay.
It's financially toxic rather than physically toxic.
And if I just ask another question, this morning when you were talking about ITP, AIHA, all them different autoimmune, actually it was Ben was talking about them. I just have a question, just maybe you can answer it. If a patient has ITP, AIHA, and the hypergamma globulin anemia, I'm showing off here, but the prognostic markers are good, with treating the CLL with FCR correct the autoimmune problems?
The answer to that is the standard treatment for autoimmune problems is immunosuppressive therapy, steroid, cyclosporin, whatever. But there are a small proportion of patients, 10-20%, are resistant to the immunosuppressive therapy. If you give them chemotherapy, around 50 to 80%, it will switch off the autoimmune process. And again, I've had to do that now and then in patients who I wouldn't normally be treating the CLL, but actually their lives are a bit of a misery with the autoimmune hemolytic anemia, and I've had to give them chemotherapy specifically aimed at that.
Okay. Thanks very much.